and it's my pleasure to welcome you all on behalf of the amazing team. A very warm welcome to our guest speaker, Dr. David Roxby, and Dr. Srinivas sir, and we have one more speaker who is yet to arrive, Dr. Narendra from KIMS Secunderabad. Before we start, I would like to thank my chairman, Dr. Nageswar Reddy sir, for giving us this platform to conduct this. And also a big thank you to the Quiddle Ortho team for organizing this. So today, session is on immunohematological approach to patient management, and we will be discussing on patients management of bleeding patients, management of ABO incompatible transplant patients, and also hemolytic anemia patients. How do we manage and recent advances? So this is something which we normally come through routinely in these scenarios are seen routinely in our job. And my transfusion medicine colleagues will agree that what a nightmare it is to deal with the hemolytic anemia case. And the reason why we hate the hematologist sometimes. Jokes apart, so we have an eminent speaker with us today, Dr. David Roxby, and he's going to be talking about how do we manage these bleeding cases and also ABO incompatible solid organ transplants and also stem cell transplant cases. He is a professor, College of Medicine and Public Health, Flinders University, Australia. He has expertise in hematology and transfusion medicine with more than 45 years of experience. He is a senior scientific consultant, Red Cross Lifeblood. He is the author of over 50 publications. He is a member of National Blood Authority, Patient Blood Management. So I welcome Dr. David Roxby to share his insights.
Good afternoon, everybody. Pleasure to be here to talk to you, and very pleased to be all here at this CME session. So my first presentation is on massively bleeding patients, transfusion practice. So in a massively bleeding patient, three aspects. One, to stop the bleeding. Two, to address the coagulopathy with appropriate use of components, and have those components available as quickly as possible. So we can look at a critically bleeding patient or critically bleeding or massively bleeding patient under four separate areas. Clinical context of the bleeding, so what is the reason for the bleeding? Is it trauma? Is it an obstetric bleed? Is it a GI bleed? Prognostic markers, so like temperature, blood pressure, acidosis, etc. The time frame in which transfusion support is required. So sometimes it's needed now. The laboratory receives a phone call and says, we would like product now. But there will be a time of delay. Also, what is the type of transfusion support that's required? So we've got tests available that can help us in understanding where the deficient coagulation factor is, and we can provide the appropriate product. These tests, these point-of-care tests, can also help us differentiate between coagulopathic bleeding and surgically bleeding. So often people interchange the term critical bleeding and massive transfusion. So not all critical bleeds are big volume. Critical could be a bleed into the brain, a critical bleed, or it could be associated with major hemorrhage. So how do we define massive transfusion? Traditionally, it used to be defined as more than 10 red cells in a 24-hour period. History there, historical thing. Is it more appropriate to consider rate of blood loss or the rate of infusion? In Australia and New Zealand, we have the massive transfusion registry, where all massive transfusions are entered into that registry. And based on that, we've redefined a massive transfusion, more than 5 red cells in a 4-hour period. So as you know, hemorrhage can have 2 different components. It can have a surgical or vascular component. It can usually be corrected by intervention of surgical intervention or embolization of that particular vessel. The more difficult one to control is the coagulopathic component, and that's due to a number of interrelated mechanisms. So consumption of your clotting factors, dilution of your clotting factors. If you give a lot of red cells, it's going to lead to clotting factors without replacement. If you give a lot of clear fluid, same thing. Metabolic effect, the hypothermia, acidosis can contribute to ongoing bleeding and coagulopathy, inflammatory process, and where there's more people on anticoagulants, antiplatelets can also contribute to bleeding. So it's a daily challenge, and studies from trauma have shown that up to 30 to 40% of trauma mortality is related to underlying coagulopathy. And coagulopathy is present in about 20 to 25% of trauma-associated cases. So these patients are presenting at the emergency department already coagulopathic. So historically, that trauma-associated coagulopathy was always thought to be due to hemodilution. They've been given some fluid, resuscitation fluid, or a lot of resuscitation fluid before they came to the ED department, and they're coagulopathic. But now we've got this concept of trauma-induced coagulopathy. So there's 2 pathways. Either the patient's hypercoagulable, where they're at increased risk of bleeding, and we know that post-massive transfusion there is increased risk of thrombotic events, or more likely, are they hypocoagulable? So here we've got alterations in endothelial function. We know the endothelial plays an important role in coagulation. We've got alteration in fibrinolysis, so we've got increased fibrinolysis, contributes to bleeding, and we could have altered platelet function. So there's 4 risk factors where coagulopathy may develop, and it all leads to this deadly triad of coagulopathy, acidosis, and hypothermia. So if you don't correct those, you have ongoing bleeding. So there's a number of independent risk factors that have been associated with predicting coagulopathy. So the first one is the injury severity score. So the higher the score, the worse the patient is injured. pH, so low pH, acidotic, low systolic blood pressure, and the patient is cold, hypothermia. And I'll explain why pH and hypothermia are very important to try and correct. So if all 4 of those parameters are present, then there's extremely high risk that that patient is going to be coagulopathic. So the complications that we see in trauma, massive transfusion, are hypothermia, derangements of your acid base, low levels of calcium or magnesium. Often that's associated with large volume transfusion of plasma products. Why does that happen? Because the anticoagulant that we use in our blood products is citrate. And citrate works by binding calcium, particularly ionized calcium. And calcium is a very important electrolyte in total body function, important component of our clotting system, as well as nerve transmission, muscle contraction, etc. The risk of hyper or hypokalemia. So stored red cells have a higher extracellular potassium level. So if you give a lot of old red cells, are we going to induce hyperkalemia in the patient? But then the reverse, if we're giving a lot of older red cells, their intracellular potassium is low. So they could suck in any potassium that's in the plasma or in the circulation of the patient, leading to a hypokalemic state. So these parameters must be measured constantly during massive transfusion resuscitation of these patients. So I've mentioned hypothermia. Why is it important? Our body systems were designed to work at 37 degrees. So the colder we are, the less effective platelets become, and they're not able to bind to their particular receptors. There's also the effect on the coagulation system, the effect on production of these the clotting factors by the liver. Also increases fibrinolysis, so increased clot breakdown, leading to bleeding. So for every degree fall of body temperature, you're going to lose about 10% of clotting factor activity. Now, if you remember in our clotting system, we don't need 100% clotting factor activity. Some of the clotting factors, you only need about 5% activity. So at about 30% factor activity, that's when it can contribute to bleeding. So by being hypothermic, what it does, it impairs thrombin generation. We need thrombin to clot the fibrinogen to convert it to fibrin. Then when we put this together with acidosis, again, our body systems are designed to work at a physiological pH around 7.1, and they have a similar effect that if you're acidotic, it affects your overall clotting factor activity. So a pH of around 7.1, you've decreased by 90% your clotting factor activity, and again, overall, you're decreasing your ability to generate thrombin. So if you combine hypothermia and acidosis, you can see that your patient is at a significant risk of bleeding, and they're already bleeding because underlying tissue injury or a postpartum hemorrhage or a GI bleed. So I mentioned the deadly triad, but now that's moved on from a triangular shape, diamond shape, and now we're including risks of hypocalcemia. So to really emphasize that now we must be monitoring pH, we must be monitoring body temperature, and we must be monitoring our electrolytes, particularly ionized calcium. As I said, if patients have plasma, platelets, that's where most of the rate is found in our blood components. So what are the prognostic markers, laboratory markers or physiological markers to be aware of? Talked about temperature, talked about pH, talked about ionized calcium, so we don't want it to fall below 1. We don't want our INRs to be more than 1.5. That's when we start to find that you've got low levels of clotting factors, along with an extended APTT. We want to try and maintain a fibrinogen level above 2 for normal hemostasis, and a platelet count above 50. So it's going to require regular monitoring. And if we're using standard coagulation tests, there's always going to be a delay to have those results come back. So sometimes it could be up to an hour. So when those results come back, you're looking at historical results. What can change in that period of time? So that's why the use of viscoelastic testing has now become more prominent. It can be at the bedside, and you can get some meaningful results within 5 minutes of the test being started, and that can guide you with appropriate product. So what to do? You've got a critically bleeding patient. What is your plan? And I'll put this in a case scenario near the end. So what is your plan? You've got a phone call, let's say from your transplant, saying, patient's got a catastrophic bleed. What is your plan? What unmatched products can you give urgently? What should you provide? Does your laboratory, does your hospital have an SOP to do patients like this? What are the consequences of massive? at the bedside, in the laboratory. So we've already talked about the risk of hyper or hypokalemia, hypocalcemia. But what about the laboratory? We don't have an infinite supply of blood and blood products, so very important for inventory management. What about the lesion of storage? Does that play a role in massive transfusion? So we've talked about that. And what are the different roles people play in these different scenarios? And it all comes back to communication, adequate communication, and it requires a multidisciplinary team approach. So communication, so from the bedside to the laboratory, the more information the laboratory is given, the more effective their response can be. And you can see clinical staff who are involved at any one time. And then the roles of the laboratory, and it's not just transfusion, it may be hematology, maybe biochemistry, and particularly in transfusion here in India, you've got two roles. You've got your donor collection role and processing, but also you've got your patient testing role. Whereas in Australia, we have a centralised blood service, so we're liaising blood service to get replacement stock. So multidisciplinary approach, good lines of communication. So what are the clinical and laboratory issues that we're looking at? So before surgery, for an elective surgery, but there's a potential blood loss, have you taken an adequate bleeding history? Have you assessed what drugs the patients are on that may contribute? Are they on aspirin? Are they on warfarin? Are they on any of the antiplatelet drugs? What about during surgery? How can you try and identify the cause of the bleed? Platelet function, fibrinolysis, anticoagulants, or is it just surgical bleeding? Same, following surgery, your patient's bleeding. Is it, again, in cardiac surgery, the heparin hasn't been reversed appropriately? Or is it coagulopathy? So some of these questions we can't answer with our standard coagulation test. Standard coag tests are not going to tell us if the patient's fibrinolytic. So elective surgery, we can do appropriate assessment of the patient. If there's projected big blood loss, you've already spoken to the blood bank and they've got product ready to go and they're aware of what's coming up. So you've developed those lines of communication already, and you're going to be able to identify the presence of a coagulopathy earlier. And if this happens, you apply the principles of hemostatic resuscitation. So in elective surgery, if we've got critically bleeding patients, massively transfused patients, the tissue is controlled, it's surgical. And transfusion, already established those lines of communication. So the response can be very rapid, and you've got better monitoring of the patient volume and temperature, and you have ongoing hemostatic monitoring. So if you haven't got point of care testing, then your standard laboratory tests are appropriate. And if coagulopathy does occur in this setting, then it's usually a late event. Your patient hasn't presented. Whereas if we've got a situation like this where you've got tissue trauma, significant trauma, this patient, I'm assuming, is going to be hypothermic. Degree of tissue injury there, he's not covered. Transfusion initiation now is going to be late. The patient's usually shocked, they're cold, and there's no form of hemostatic monitoring at the site of that accident. And as you've seen, up to 25% of patients like this present in a coagulopathic state. So what is damage control resuscitation? And transfusion plays a role here. So it's permissive hypotension. We're not aiming to resuscitate to a normal blood pressure, and we must avoid these parameters talked about. Rapid control of bleeding, have an understanding that there's 25% risk of coagulopathy, and so we want to implement early use of appropriate blood components, and the use of massive hemorrhage protocols. The suggestion is to have a ratio of red cells to plasma platelets, but once we've got some definitive laboratory results, move to an individual patient goal-directed treatment plan. Once your patient has been stabilized, revert back to restrictive transfusion regime. I want to inappropriately transfuse the patient, and I'll talk about the massive protocol, but when you've got to this stage where you've stabilized your patients, it's really important to let the laboratory know that patient's stable, we're not going to need your urgent responses anymore. And part of damage control surgery, damage control resuscitation is damage control surgery. It's just to stabilize the patient, try and control the bleeding. It's not definitive surgery to fix the fractures or anything like that. Stabilize your patient, come back a day or two later. So here, this diagram, this is your damage control, and there's a number of things that are involved. Damage control surgery, permissive hypertension, rapid rewarming. So in these massively transfused patients, the products, the fluids that you're giving these patients must go through a blood warmer. Because remember, our components are stored at 2 to 6 degrees. We don't want to contribute to that underlying hypothermia. Limit the use of crystalloid or colloid, early use of the ratio of 1 to 1 to 1 red cell plasma and platelets, and identify if these patients have hyperfibrinolysis or they're low in fibrinogen. Let's look at our hemostasis process. Normal hemostasis is a balance between bleeding to death and clotting to death. So we want to try and balance it. So often when we see these patients, they're in an imbalance. They're coagulopathic. So how can we address that? So this is the vicious circle. We've got hemorrhage, we've got platelets that are activated, the clotting factors. So these are all being consumed. Fibrinolysis, so it's a bit like that triangle or diamond. So we've got to try and break that circle to limit the bleeding. So what products, components do we have available? Red cells, platelets, plasma, cryoprecipitate. We may have more specialized products such as fibrinogen concentrate or 3 or 4 factor prothrombin complexes. And do we have available cell salvage, intraoperative cell salvage, where it helps to conserve the patient's own red cells? We can aspirate from the site as long as there's no contamination, as long as there's no bowel damage, harvest that free fluid and wash red cells, and those washed red cells can be reinfused to the patient. So what are our goals? We've got to think about patient blood management. So we want to treat early, we want to treat adequately. We don't want to give too little, too much. If they're too wet or too dry, too wet could lead to pulmonary problems. And we want early goal-directed coagulation management. So for instance, if the patient's got very low levels of fibrinogen, but they've got adequate numbers of platelets, don't necessarily need to give platelets. So goal-directed therapy. So control the bleeding, control of acidosis, pH, minimize the coagulopathy. And that then leads to minimizing unnecessary transfusions, minimizes organ function. So we need to be proactive rather than reactive. And it comes back to good communication between all members of the team. So what can we do to try and restore normal hemostasis? We can use our products with procoagulant activity. We can use antifibrinolytic agents to minimize or stop the fibrinolysis, so tranexamic acid. This we consider post-event, where there's an increased risk of the patients become prothrombotic. So what are our options? Sure, you've all seen these: red cells, plasma, platelets, cryoprecipitate. This is fibrinogen concentrate, factor 7A. Factor 7A has fallen out of fashion, not to be not of much use. It's usually, or in our situation, it was used as a last-ditch effort where couldn't control the coagulopathy and our cell savers. So basically, blood, the fluid's aspirated into a cardiotomy reservoir. There's a centrifuge in here. Blood goes from there into there. There's saline that then centrifuge is spinning, separating it. You're filling it with harvested fluid. The centrifuge bowl fills with red cells. Then you run a litre and a half of saline through that bowl, washes off any activated clotting factors, any fibrin, fibrinogen. So it's just red cells in saline. So if you give a lot of the washed red cells, it can lead to a hemodilution. It can contribute to a coagulopathy. So we're saving patients red cells, but if we don't address the risk of hemodilution, we can actually be causing problems as well. So I like this diagram. It's a diagram of the hemostatic process. So primary hemostasis, secondary hemostasis, and then clot breakdown. So these are all the normal steps in the hemostatic process, but it identifies where the blood components, where their role is. So you can see in primary hemostasis with platelets, fibrinogen, and platelets. And fibrinogen is probably the most important clotting factor. To address any deficiency, this secondary hemostasis would plasma, and for anticoagulate, and fibrinogen as well. And to fibrinolysis, we could give tranexamic acid. So why is fibrinogen the most important clotting factor? We need fibrinogen to clot, to produce the clot. If we don't have enough fibrinogen, you may have adequate amounts of your other clotting factors, but if you've got nothing to clot, you're going to bleed. So fibrinogen is the first clotting factor that falls in critical bleeding because it's being consumed to try and stop the bleeding. So it accounts for about 92% of the overall total of our clotting factors. And so these are where everything fits in. So we've got platelets, we've got cryoprecipitate here, or substitute cryoprecipitate for fibrinogen concentrate. Here we've got our plasma again. Here again, fibrinogen's got an important role, and here is where we'll be using tranexamic acid to limit or stop fibrinolysis occurring. So what is a major hemorrhage protocol? It's a process to provide blood and components in a structured manner in a very short period of time. And it's based on evidence guided transfusion guidelines. So in your massive hemorrhage protocol, you will have defined what's in the shipper that you're going to send to the bedside. Then it facilitates good communication. Instead of getting multiple phone calls from the bedside saying we want some red cells, and then 5 minutes later, plasma, platelets, it all comes in the one box. But remember, it's not a prescription. You may have provided red cells, plasma, platelets, cryo. Doesn't mean you have to use them. This is where the use of viscoelastic testing gives you that information to tell you which product to use. So it's a logistic pathway. It improves communication, decreases the time to supply the products, and you can have these massive hemorrhage packs already pre-prepared in your cold room. So one phone call, where's the patient, what's their gender, what's their problem, what's the projected blood requirements, and the location, and it goes. So within minutes. So this is just an overall summary. How do we recognize the potential for a major hemorrhage? So we've got some laboratory, or we can have um, different things that we can monitor. So if the patient's systolic blood pressure is less than 100, or if their heart rate's up, positive fast scan, if blood loss is large, any one of these could be used to activate a massive hemorrhage protocol. There are scoring systems using various physiological or laboratory parameters. So, for instance, if your systolic blood pressure is less than 90, score of 1. Based on these parameters here, you've got a score of 4, more than 2 in any one of those, incidence or the requirement for massive hemorrhage response is high. There's another one called the TASH score, and here we're also incorporating the use of laboratory parameters. So it's a scoring system as well. So you can see if the score's 24 or more, then there's 85% chance that these patients will require a massive hemorrhage. If you can't remember all those parameters, a simple one is the shock index. The heart rate divided by the systolic blood pressure. If it's greater than 1, then the risk of a massive hemorrhage response is quite high. So I've talked about ratios. What's the appropriate ratio to? Remember, most sites now are using components. So a 1:1:1 ratio of red cells, plasma, and platelets is not directly equivalent to a unit of whole blood. So there's been a number of large randomized controlled trials, and the suggestion is that a 1:1:1 or a 1:1:2, 1 red cell, 1 plasma or 2 plasma, and 1 pool of platelets. It's not one individual bag, it's the pool of platelets, tends to decrease the bleeding and the risk of death due to exsanguination. The risk of that has been decreased. But there's still ongoing debate about what's the ideal in these situations. So what's the blood bank or the transfusion laboratory's role here? Phone call, automatically supply your pre-prepared pack, and then the laboratory prospectively sets up their next pack, and the laboratory would know their protocol says 4 red cells, a couple of plasmas, platelets, ready to go when you've got the next phone call. So it's minimizing unnecessary communication. You've already got the information, and these are the packs that we used. So they needed to be packed with ice bricks in a particular configuration. Want to maintain proper storage conditions. So we could maintain red cells and plasma up to 24 hours in these packs using the appropriate packing configuration. So the packs, it varies. So the packs would contain either O positive or O negative red cells. It's up to the individual hospital or laboratory to define what they have in there, or it could vary depending on the cause of the massive hemorrhage. So for instance, in an obstetric hemorrhage, be wanting to probably provide more cryoprecipitate than plasma. Fibrinogen levels increase significantly in pregnant women. So this is from the hospital I worked at. This is the adult massive transfusion pack. So everybody knew, the anaesthetists, the surgeons, the ED guys, they knew if they rang for the first pack, this is what would be in there. At the same time, these are the responsibilities of the staff. They would be doing their ROTEM. This is a reminder for everybody to monitor those biochemical parameters, and these are the parameters aiming for to minimize coagulopathy. So that's adults, but children and babies are different. We've got a massive transfusion response for them, but children in these settings are transfused on mils per kilogram. So obviously, if you're one that's 1 year old, only give in the pack one red cell and one plasma. So that's why it's important to get the patient details as well. So what choice of products do we have? We can give group O unmatched red cell. We can give group, if we don't know the patient's details or blood group, we can give ABO specific if we know their blood group. If we've got enough time, we could provide cross-match blood. We have the ability to electronic release, so group and screen and electronic cross-match. What about plasma? AB plasma, no, the frequency of AB is very low in the population. So there's a move now to A plasma instead of AB plasma, where you do not know the patient's blood group. Now, it's safe. The level of anti-B in a group A person is very, very low. So it's a safe procedure, and you've got 45% of your population is going to be A. Whereas AB in Australia, it's 4%. Only male donors are used for plasma donation, so that's 2%. And some of those AB plasmas are made into cryoprecipitate. So we've got less than around 1% of our donors would be eligible. So this is a consensus statement that we recently published in Australia, guiding the use of O positive and O negative. So the recommendations are women of childbearing age, so less than 50, males up to 18 years of age, we give O negative if we don't know their blood group. Patients outside of that, so all males and women older than 50, we would give O positive. And we would limit the amount of O negative red cells we would provide. So normally we'd provide 2 units, and we would really be insisting on a sample because we don't want to be continually issuing O negative. So the maximum number of O negative units we would issue is 4. Still haven't got a sample, then we'd move to O positive, because in Australia we've only got 6.5% of our donors are O negative. What about coagulation monitoring? So we can have this point of care testing at the bedside. So the viscoelastic testing gives us an overall picture of the hemostatic process, whereas our standard coag tests are only looking at when thrombin is first generated. It tells us nothing about primary hemostasis or clot breakdown. So viscoelastic testing has multiple endpoints. It tells us about fibrinogen, platelets, about clotting factors. So now we've got a guide for selective blood component therapy, and it also can demonstrate whether the patient is fibrinolytic, whether they should be given tranexamic acid. So with the introduction of this technology, it's reduced, or it reduces inappropriate use of blood and blood. So when should we use it? Any of these scenarios, but now there's a move also to use it in non-theatre pre-interventional procedures, such as a kidney biopsy. The INR may be 1.6, but it's adequate hemostatic reserve, whereas by doing a ROTEM, it gives us better guidance on whether we need to correct that INR or not. And it's based on the viscoelastic properties of a clot. Basically, as the clot develops, there's a wire that's in the clot, and the degree of force to turn that wire or cup increases with the clot. That force is translated into graphical displays and also numerical output, and you get different patterns which are related to different causes. So there's a number of different parameters. So basically, the way to interpret these, what I like to say is, if it's long and skinny, got a problem. If it's short and fat, it's okay. And I'll show an example shortly. So there's if you're using viscoelastic, there's 6 simple questions. Is the patient bleeding? But what's the VHA, the viscoelastic? Is it normal? So If the VHA is normal and the patient's bleeding, highly unlikely to be associated with an underlying clotting factor deficiency. So you have to consider other possibilities. Is it an anticoagulation problem? Is it a surgical problem? You need to correct that. But what about if the VHA test is abnormal? Question you ask then, the patient bleeding or at high risk of bleeding? No, sit and do nothing. Already identified where the potential placement would need to occur, but if they're not bleeding, do they need coagulation placement? But if it's yes, then the first question you're going to ask is there fibrinolysis? So this is fibrinolysis. So it looks like a pufferfish sausage. So this is a normal trace, but if it's tapering off, that's fibrinolysis. So you give tranexamic acid. The next question is, should I replace fibrinogen? Fibrinogen will influence the amplitude of your traces. So if it's skinny, fibrinogen. Next question, should I give platelets? Again, got an individual test for fibrinogen. But again, if the traces are skinny, it's platelets or platelets and fibrinogen. The last thing I'd be thinking about would be placement of clotting factors. And clotting factors can be influenced by the level of fibrinogen. So it's better to address the deficiency of fibrinogen and fibrinolysis platelets, or you'd consider giving FFP. And this technology allows the use of algorithms. So again, it simplifies the replacement of your clotting factors. I like to teach pattern recognition, which helps. You can look at the numbers, but pattern recognition to me is a lot faster than looking at numbers. So I'll just finish with this case. This was a very challenging case. 16-year-old male playing soccer and had a blunt abdominal. He presented in the ED with vasculomas 3, non-verbal, unresponsive. At the oval, his systolic blood pressure was 70. By the time he got to hospital, it was down to 50. Look at his pH, 0.9. So he's already got two parameters that contribute to coagulopathy. Look at his hemoglobin. So this is a 16-year-old male. What would you expect a hemoglobin in a young gentleman to be? 15, 14? It's 50. Significant bleed. His bar scan was positive. He had to be resuscitated a couple of times in ED. So his injuries included severely lacerated liver, portal vein, adrenal gland, duodenum. He had hemopneumothorax, coagulopathic. This was the injury to the liver. That was, so you get the call. We've got this. What are you going to do? What is your response in this situation? This was his rotem trace. Short, long, and skinny. Typical severe fibrinolysis. This is the fibrinogen, flat line. So he's presented already coagulopathic. So the testing goes from left to right, but you read from right to left the way you treat. Address the fibrinolysis, this, and then they were really skinny, so this required platelets as well. So he was resuscitated, he had a hemihepatectomy, and everything was repaired. It was extended surgery. It was extremely difficult to control the surgery. So at one stage, they were considering total hepatectomy and putting him on the priority list for a liver transplant, but he didn't have to progress to that. So these are the original CT scans. So that's the remnant of the left liver, packing. He was packed, continued to bleed. Right liver. This is the hematoma and the duodenal trauma. You can see the damage to the kidney and big retroperitoneal hematoma. Look at his laboratory results. Saw these. If he didn't have a rotem in the laboratory, hemoglobin. Well, let's look one. Hemoglobin 48, platelets 3. Fibrinogen, not too bad there. Already had some. FDPs are up. So over this period of time, it was extremely challenging to resuscitate him. So this is his blood product use just in the first 12 hours. And I've tried to put in the laboratory results as well. So you can see it was really difficult to give enough product to maintain or control that hemostasis. So over that first 12-hour period, he had 74 cells, 60 odd plasma, bio, platelets, prothrombin. We even gave him factor 7A. How would you deal with a situation like this? What are your lines of communication? Here you collect blood on site. What's your process for getting more donors in? So we had challenges. The surgery had to be stopped. We ran out of cryoprecipitate in South Australia. It had to come from state. Lots of communication happening. He survived. That's his liver 3 months later. So it was a successful resuscitation and outcome. He survived, happy young man. So overall, what's the hemostatic resuscitation process? We can start with O negative, unmatched red cells in a ratio of 1 to 1 to 1 or 1 to 2 to 1 for plasma red cells and platelets. But in the same time, we would implement viscoelastic testing to give us better guidance on appropriate use of blood and blood products. If you don't experience massive transfusions, critically bleeding patients often, but you do see them, the British guidelines recommend that where you don't see them often, you'd have dry runs at least once a year and include all the different players in that. So the laboratory, biochemistry, hematology, transfusion, emergency department, theatres, go through a dry run. So in summary, hemorrhage control is really important. Hemostatic resuscitation early likely limits complications, improves mortality and outcome. Early use of fibrinogen and platelets particularly contribute to improved outcomes. The use of massive hemorrhage protocols improves turnaround times, improves communication, improves time it takes to provide these products, and viscoelastic testing provides patient-specific goal-directed product replacement. So thank you everyone for your attention. Are there any questions? Happy to talk afterwards. Okay, the question was about the use of whole blood. So whole blood, there's been a resurgence in the interest and use of whole blood. Whole blood, it doesn't have to be fresh. Whole blood, the labile clotting factors, so the labile clotting factors will deteriorate, but they plateau off at around 75 to 80% factor activity, and that's still adequate. We always used to say we have to keep platelets at room temperature, but in stored whole blood, the platelets are still active. They've become activated. So in a bleeding situation like this, you're giving one product that's got adequate clotting factors, you're giving activated platelets. And so you may not see an increment in the platelet count, but you may see a clinical effect, a decrease, particularly if it's coagulopathic bleeding, oozing, you may see that ooze stop. So personally, I think it has a role in critical bleeding patients or cardiac patients that are bleeding. So not only are we interested in whole blood, there's now big interest in cold stored platelets. So platelets is normally stored at room temperature, 5 to 7 days. But think about if you stored platelets, some of your platelets in the fridge, they're going to be, you can keep them up to 14 days. And they're hemostatically active, but again, only in a critical bleeding situation. You wouldn't use cold stored platelets to try and maintain a prophylactic platelet level in a hematology patient because they're not bleeding. So I think in the years to come, we're going to see whole blood, cold stored platelets, but for specific scenarios. Not so sure about fresh whole blood. It's been stored for less than 24 hours. So I think we'll be moving towards whole blood, cold stored platelets, and fibrinogen concentrate that will go out on our medical retrieval teams via helicopter or road. So everything's there. The next ideal would be have a portable VHA that you could quickly do it just at the bedside or the accidents.
Have you seen any cases where the patient is having cold antibodies
Cold?
with stored blood if you are giving?
Oh, no, because we would normally give the blood through a blood warmer. So cold antibodies are not going to be a problem. I guess the thing is in scenarios like this, another SOP you would need to consider is your patient had antibodies. They want a life-threatening hemorrhage. What do? You have to give incompatible blood. So, but remember, the important thing is to give ABO compatible. We don't want an intravascular hemolytic transfusion reaction. The other antibodies, if they're going to react, going to be extravascular. But remember, in these critical bleeding situations, resuscitating your patient, fluids, they're bleeding, giving them red cells, the immune system's probably shut down as well. And so the likelihood of transfusion, an acute transfusion reaction, is extremely low. Maybe a delayed. We had a case, a postpartum hemorrhage, where the woman had 3 antibodies. We gave her something like 37 units, 21 of which were incompatible. Had a very weakly positive direct antiglobulin test and the occasional spherocyte. It was a laboratory observation. There were no clinical signs and symptoms of hemolysis really go up. So can't not transfuse a patient. You don't want them exsanguinate. I think I might have gone over time a little bit, sorry. Any other questions? Sorry?
In case of emergency, you give positive.
Yes.
Do you monitor or give you anti-D?
Well, there's 2 points there. People are concerned about, one, we don't know the patient's blood group and they've got an anti-D and we give them, and it's a male or female, and we give them D positive blood. What is the risk of a hemolytic transfusion reaction? There's a risk, but it's extremely small. And lots of work done in the last couple of years, modelling, so the risk is extremely small. Similarly with the production of an anti-D, given to, particularly in a Rh negative women where you've given positive blood, what is the risk of anti-D developing? And again, in a trauma situation, the risk is quite low. But if it's in a routine transfusion setting where you're giving 1 or 2 units, it's extremely high. Again, it's multifactorial. Would I give RHD immunoglobulin to an Rh negative woman who's been given Rh positive blood? No. How much does 1 vial of RHD immunoglobulin, what's the volume of red cells cover? In Australia, it's about 6 mils. The volume of red cells in a unit of blood, about 300. So if you've given multiple units, you're going to have to give multiple, and that can lead to hemolysis. Well, and then as we develop that consensus statement, they said, well, why don't you do a red cell exchange? Well, we're going to use a lot of O negative red cells. So no, we don't use RHD immunoglobulin. We don't not consider doing a red cell exchange.
I missed most of your talk, but I think like the way we were discussing earlier at lunch, in transplant patients, What is your experience using um, the products like the PCC? What is it?
Prothrombin, yeah.
Yeah, prothrombin
Prothrombin
concentrates
complex,
and
concentrate.
or the fibrinogen directly. Do you think those things actually help, or have you had a chance to look at it?
In my experience, we didn't use PCCs very much at all, although there was one anaesthetist who insisted on giving 1,500 units ad hoc for a transplant, even though the ROTEM was normal. So
Oh,
yeah,
so
so we would normally correct with plasma if required, or fibrinogen or platelets.
we have used it, and yeah, I think we're going to publish it soon also. It has helped, especially
Yeah.
in patients where there is high INRs. The
Oh,
PPINR
absolutely.
is very high, basically the acute and chronic liver failures.
Yeah.
So in these patients, it has helped us in reducing the amount of transfusions later.
I was going to say, particularly if you're worried about fluid overload,
Yes, yes.
you know, to get, you know, the same with fibrinogen. You wanted to say give a couple of grams of fibrinogen and use FFP, you'd have to give something like 1.5 litres of plasma, whereas a dose of cryoprecipitate, depending on what you're using, could be as little as 100 mils. So same thing. It's patient specific again. You don't just, but yeah, we've done that. We've done a couple of hemophilia patients.
An intensivist being an intensive often see with disseminated intravascular. In them, as part of last risk, we do use did use. What's your experience on that? As you said,
Yeah.
what are the drawbacks?
Well, when it was in fashion, we used to use a lot of it. There were two rules: they must have adequate platelets, they must have adequate fibrinogen, and they must be warm. But the studies showed that it wasn't leading to improved outcomes. As I said, in our experience, it was used as a rescue therapy. So we rarely use it. We hold it. The major use is patients with factor VIII inhibitors now. Don't routinely use it in other scenarios.
Thank you, David. Now move on to the next session. The next session is on recent advances in hemolytic anemia. So the session is going to take by Dr. Srinivas. That is MD in transfusion medicine from PGH Chandigarh. More than 10 years of experience. Happy to say that he's established a transfusion medicine department in ESAC as well as started MD course. So welcome, sir. Thank you.
Very good afternoon to all of you. So, topic was recent advances in hemolytic anemia, sort of restricting it to autoimmune hemolytic anemia. So before getting into the session, I just want to take some time so that I can drag your attention and pull my nose back. So at the time of preparation of my slides, I just in the end made this small poem. So anybody can recognize by reading it something. So my dear, look around. You the one who is staring at the stars. Truth is in front of your eyes. You can't be blind chanting. Either you can't achieve any benefit and get life wasted. Yes? So it's nothing. I just copied it from one of the famous song in Rudravina. So it says that like Chutupakala Chudra Chinnavada, Chukkalo Chupu Chikkunnavada. So autoimmune hemolytic anemia cases comes in front of you, but you fail to recognize things, right? So this song is apt to describe that autoimmune hemolytic anemia. So it was written by Sirivenala Sitaram Shastri garu. So as in the introduction, Dr. Pragati said, like there are lots of headaches with the hematologist dealing with hemolytic anemias. I would like to lower her stress. Maybe this presentation may help her. So I'll be presenting my slides in this order. So immunology, hematology, and blood transfusion. Clubbing it becomes immunohematology, IHBT, which stands for other synonym of transfusion medicine. So ideally, when a patient of hemolytic anemia appears, the first thing they do is the reverse order. So they start with the blood transfusion, tries hard but fails, and then they look for other parameters, and then by the time it becomes worse, aluminized or something, it becomes very difficult for the blood bankers. So the basic way out is try to understand immunology, uh, understand the hematology, laboratory wise and clinical wise, and then the end will be the blood transfusion. The best example for patient blood management, where the idea of patient blood management is to avoid transfusion. So anemia, so the way it presents, it presents as anemia, then hemolysis, immunology, and you'll find auto. How we blood bankers find it. So it's a heterogeneous group of diseases involving immune destruction of erythrocytes due to autoantibodies and complement. Either this can happen intravascular or extravascular. So estimated evidence is 1 to 3 cases per 1 lakh per year. So more common in 40 years old and in early childhood. So ideally what we see here is most commonly in the young females. Right, and even mortality is reported in 4% of the cases due to infections, Evans syndrome, acute renal failure, and major thrombotic events. How autoimmune hemolytic anemia is basically classified based on thermal amplitude at which they react and subclass. So the below is a monospecific diet. Based on that, they have been categorized into warm, cold, and atypical autoimmune hemolytic anemias. So in warm, we have it has been classified as primary and secondary drug induced. Cold antibody autoimmune hemolytic anemia have had cold agglutinin disease, which recently in 2022 has been included by WHO under clonal B cell lymphoproliferative disorder. Apart from that, we have secondary cold agglutinin syndrome (CAS), which means underlying conditions are there where it is categorized under CAS, and paroxysmal cold hemoglobinuria. Apart from that, we have atypical autoimmune hemolytic anemias like mixed cold and warm and diet negative autoimmune hemolytic anemias. So this is further how the autoantibody characterizes. In warm, so warm autoimmune hemolytic anemia prevalence is more. It is almost 70%, followed by cold autoimmune hemolytic anemias like 25%, and rest are all cold and paroxysmal cold hemoglobinuria and mixed type of autoimmune hemolytic anemia. If you see the class, in warm it is IgG, in cold it is IgM, so which can activate complement. In very few conditions, even the warm type can activate complement, but fixing is a bit weaker. In mixed type of autoimmune hemolytic anemia, we can see both warm and cold. And if you see the thermal range, warm autoimmune hemolytic anemia has a broad range. It is active at 37 degrees Celsius, whereas cold is more specifically to 4 to room temperature. You can see more of agglutinated sample when received at blood bank. And specificity wise, warm autoimmune hemolytic anemia specifically reacting with RS system, and cold I and small I blood group systems. Further, yeah, this is secondary autoimmune hemolytic anemia. The causes are yeah. Warm autoimmune hemolytic anemia. They include underlying conditions like lymphoproliferative disorders, hematological disorders, solid tumors, autoimmune and inflammatory disorders like SLE, primary immunodeficiency syndromes, APLA, infections, EBV, CMV infections, transplantation. Even recent COVID infections has also caused warm autoimmune hemolytic anemia. Apart from that, cold autoimmune syndrome has uh, occurred because of infections like mycoplasma pneumonia, which is most commonly seen in our place during winters. In households where um, bigger families are staying in a smaller space, like the older people are affected, infectious mononucleosis in case of pediatric patient and other malignant diseases. So these are the basic mechanisms of RBC detection, whereas your IgG warm type of antibody activates this macrophage mediated antibody dependent cell cytotoxicity, and these coated cells will be removed by spleen where extravascular hemolysis happens, and the spleen further is also actively produces autoantibodies, whereas your cold agglutinins anti-complement will activate complement mediated antibody dependent cell cytotoxicity, can cause intravascular hemolysis by activating membrane attack complex, and extravascular hemolysis do happen in the liver. So you can see in warm type there is a spleen, whereas in cold type you can feel the hepatomegaly. So AHA pathogens, other factors involve genetic factors. So more predisposed to HLA B8 and BW6. Also linked to immunoglobulin heavy chains, variable regions, and immunoglobulin light chains. This cytotoxic T lymphocyte antigen 4 polymorphisms also will lead to development of autoimmune hemolytic anemia. Congenital immunodeficiencies like Kabuki syndrome, ALPS, because of reduced self-tolerance and immune maturation, lack of immune maturation can lead to autoimmune hemolytic anemias. Whereas environmental factors, if you see like infections, where these infections antigens can mimic RBC antigens, which leads to molecular mimicry. And further polyclonal B cell activation, neoplasms like CLL, NHL, ovarian teratomas, thymomas can also lead to autoimmune hemolytic anemias. Further drugs like penicillin, alpha methyl dopa, and other cytotoxic drugs can also induce autoimmune hemolytic anemia. So presentation wise, if you see the patients present with fatigue, jaundice, dyspnea, dark colored urine, and other signs like infection, organomegaly, skin rashes, arthralgias. So the basic differences between warm and cold autoimmune hemolytic anemia is most commonly warm type of autoimmune hemolytic anemia is seen in younger age females, and whereas cold will be seen most commonly in older age patients. So mostly we see acute presentation in warm type of autoimmune hemolytic anemia where you see hemoglobin levels of 2 grams, 3 grams. While comparatively cold will be like milder anemia, but still when you pick up the samples, you can easily identify the difference between warm and cold type of autoimmune hemolytic anemias. So diagnosis wise, the first and foremost thing whenever we see a DAT positive, we just ask our residents to go and look at the patient. So most of the uh, things can be elicited by taking a clinical history and presentation of the patient. You see the warm type of autoimmune hemolytic anemia, there could be past history of infections or drop in hemoglobin are treated outside. Whereas in cold, if you see at the time of presentation itself, so a group discrepancies, which like O group seems like AB blood group. So this gives some clue like, so there could be possibility of some autoimmune hemolytic anemia. In such cases, you need to go and look for additional history like any acrocyanosis in the peripheries, right? So for, spontaneous, we just identify many a times we get doubt when we see a agglutinated sample or a lysed sample. So this gives a clue regarding some autoimmune hemolytic anemia going on in the patient. So the gold standard for diagnosis is direct Coombs test. Ideally, in most of the setups, we use polyspecific antisera, so which consists of IgG and complement. But in addition, we can do a monospecific anti-sera, which gives exact clue which is warm type, which is cold type, like anti-IgG, anti-complement, IgA, and IgM. So ICT can be useful in mixed type of autoimmune hemolytic anemia where both DCT and ICT could be positive. So it also helps you to after doing adsorption and elution in difficult cases. Hematological parameters to be monitored: reticulocytes, indirect bilirubin, LDH, which are moderately elevated. So haptoglobin will be reduced. In case of hemolysis in the urine, you should also check for hemoglobinemia, hemoglobinuria, and hemosideruria, which can occur in hyperacute and massive form. These other investigations also need to be added to your investigations, where bone marrow evaluation in cold agglutinin disease at the diagnosis, because WHO has included it as a clonal B cell lymphoproliferative disorder with no signs of any malignancy. CAD, it has to be done. Bone marrow evaluation has to be done. Whereas in warm autoimmune hemolytic anemia, in relapsed and refractory cases to first line therapy, this has to be added. Whole body CT scan to rule out any organomegalies, serology for infections and autoimmune diseases, including cardiolipin and beta 2 glycoprotein has to be done. So endogenous erythropoietin levels has to be assessed in cases which are resistant to treatment. And further molecular analysis and next generation sequences in difficult cases where autoimmune hemolytic anemia is not responding to your first line and second line of drugs. So this is the diagnostic workup in autoimmune hemolytic anemia. If you see, you have to suspect whenever there is a raised LDH, bilirubin, and absolute reticulocyte count, and reduced haptoglobin. If there is any hemolysis, perform DAT. No hemolysis, it could be due to other, you have to rule out other conditions. So if DAT is positive, you have to go for monospecific DAT. And based on the picture, for IgG plus, it could be warm. If it is C3D, it could be mixed or cold autoimmune hemolytic anemias. So that after this, I'll go with the cold type. So after this, we have to do a cold agglutinin titers. If the titer is more than 64, it falls into the category of mixed type. If it is less than 64, it could be cold agglutinin disease or cold agglutinin syndrome. If underlying disease is not there, it goes towards cold agglutinin disease. You need to do a bone marrow biopsy, bone marrow flow cytometry, and electrophoresis in such cases. Whereas in cold agglutinin syndrome, you have to work up for underlying associated disease. Basically, the treatment has to be given in the direction of the underlying disease. Whereas in warm type of autoimmune hemolytic anemia, uh, if there is an underlying disease absent, it is primary warm type of autoimmune hemolytic anemia. If it is secondary, then you have to go for underlying cause and work up for underlying cause, and the treatment is based on the type of underlying disease. So there is one more entity called DAT negative AHA. So where your first polyspecific DAT will give you a clue regarding autoimmune hemolytic anemia, where you do monospecific DAT, it gives clues regarding warm, cold, and mixed type. Where in some cases it can't be ruled out, but you have to add some additional level. So where you can do it with testing with cold washings and trying to use ionic solutions, or using more sensitive methods. I'll be telling you regarding that in the next slide. And doing a dual direct antiglobulin test to detect warm IgM. So basically, the diagnosis for this is made based on the exclusion of other hemolytic conditions. Once these are ruled out and there is a response to steroid therapy, it is labeled as DAT negative autoimmune hemolytic anemia. These are the different methods of DAT. So ideally, most of the blood banks will be dealing with conventional tube technique, which is the gold standard. So the sensitivity is around 300 to 500 molecules per red cell. In cases where more sensitivity is required, you can use flow cytometry, where it can catch up to 30 to 40 molecules per red cell. So right now, most of the setups have moved to column agglutinin test, so where the sensitivity is around 120 to 180. So further, you need to, so not all positive DATs are true positives. There could be false positives ideally. So if you take a history clearly, you can notice few things like the patient might have been given RSG immunoglobulins or anti-thymoglobulins, or the patient might have anti-cardiolipin lupus antibodies, or patient might be previously transfused, is in the transition phase of alloimmunization where your DCT comes positive. So in few percentage of healthy blood donors, this data is common, but they don't show any clinical evidence of autoimmune hemolytic anemias. And in hospitalized patients, around 0.3 to 8% shows that positivity without any clinical evidence of autoimmune hemolytic anemia. So prognosis markers, what to look for. So if you see reticulocytes, anytime if you see in the peripheral picture reticulocytosis is there, it is a good sign. That means your marrow is effectively compensating. So if there is any reticulocytopenia, it indicates a poor prognosis with greater severity and slower response to your drugs. Further, reticulocytopenia gives an indication to the hematologist to add erythropoietin in addition, because the problem there might be these autoantibodies may be affecting the precursors in the bone marrow itself. That may be the reason which lead to reticulocytopenia. LDH is high LDH characteristic of intravascular hemolysis and hyperacute forms. You need to rule out other cases of high turnover like inflammatory condition. Haptoglobin is the most sensitive, which will help you to know whether the patient is remission. This will get normalized in the last upon treatment. So further, these markers have confounders. So other confounding features you need to exclude. This is regarding severity of anemia in cold agglutinin disease, where if you see the hemoglobin is the hemoglobin levels is inversely um, correlated with hemolysis, where more the hemolysis, less will be the hemoglobin. But it doesn't correlate with the IgM levels. If you see in the mild anemia, it is around 6.7, 4.2, and 5.5 in severe anemia. So IgM level doesn't correlate with the level of hemolysis in cold agglutinin disease. So in some cases where compensated hemolysis happens, so even the LDH bilirubin levels will be at the lower side only. So these are the current therapeutic modalities which are available. First line is steroids. 80% response is seen in a warm type of autoimmune hemolytic anemia, but in cold agglutinin disease this doesn't work. If even if you want to treat those patients, uh, probably you have to use higher dose of steroids, and that may lead to complication in patients. Second line of drug, rituximab, which revolutionized this anti-monoclonal antibody. Monoclonal antibody has revolutionized this inflammatory conditions and hematology, where it is helping to treat both hemolytic anemia and cold agglutinin disease. So it is like Rajnikant, who is a superhero, where Dr. Roxby will be going next for next session in Chennai. So it's like a superhero, rituximab. So it almost helps in 80 to 90% of these cases. Previously, splenectomy used to be considered. So more, where people have a severe problem with the spleen, splenomegaly, most of these cases were going for splenectomy, where steroids were the only option. But now this is reserved for young females who are of reproductive age. So in those cases and younger patients only, this is being done, because in older patients, because of the infections, this is not preferred modality of treatment. So 80% response is seen in, even with splenectomy. Whereas in refractory or relapsing cases, they have additionally support with immunosuppressant. They can use mycophenolate mofetil, which is having 80 to 100% response. So this is giving good response in refractory cases. IVIG can be used in pediatric settings as well as in Evans syndrome. Plex can be considered, but in severe cold agglutinin disease, it is category 2 indication, which is second line of treatment. And this is weak recommendation is there as per ASFA guidelines, even in warm autoimmune hemolytic anemia. So it comes under category 3. So newer modalities of treatment have arrived, so which include B cell targeting antibody based therapies, B cell receptor inhibitors, plasma cell targeting antibody based therapies, complement inhibitors, and neonatal FC receptor inhibitors. So you see this, this is the monoclonal antibody armamentarium. These are the weapons which can be used in autoimmune hemolytic anemia. Rituximab, basically monoclonal antibody, which can effectively useful in warm type of autoimmune hemolytic anemia, can act against B lymphocytes. Apart from this, there are other set of drugs being under study. So clinical trials been happening. So apart from that, plasma cells, this anti-CD38, daratumumab and cetuximab can also are helpful in plasma cell. So this will be inhibiting this plasma cell. Mostly, this is being used in autoimmune hemolytic anemia resistant and in transplant cases. So this drug is being utilized. Whereas in cold autoimmune hemolytic anemia, so this is targeting this complement activation. So right now, sutimlimab, which is having FDA approval, is being utilized. But as far as our hospital, we are using rituximab along with combination with fludarabine and bendamustine, so which are giving good responses. Whereas rituximab itself gives around 40% responses in cold agglutinin diseases. Therapeutic algorithm in a warm type of autoimmune hemolytic anemia. They start with steroids initially. If there is a response, they have to be tapered off, and once complete response is there, they have to be um, stopped for follow-up. If in case if it is severe or if there are any relapses or failure, so prednisolone along with rituximab is added. So because prednisolone takes time to show its effect on warm type of autoimmune hemolytic anemia antibodies. So prednisolone will be taken care in the beginning and after followed by rituximab. So if there is any failure in such cases, we can add immunosuppressants. In failure in such cases, also resistant cases can suggest for a splenectomy. Therapeutic algorithm for cold agglutinin disease. Most of the conditions when you suspect a cold agglutinin disease, a symptomatic disease with very mild symptoms, wait and watch approach should be done. So first thing you have to tell them to keep them warm and use any kind of fluids being taken should be warm. So this can help to recover from those cold agglutinin symptoms. Treating of the underlying disease like mycoplasma pneumonia, so use of macrolides can relieve the symptoms. Whereas symptomatic anemia or bothersome fatigues, circulatory symptoms are there, you need to treat. You can use bendamustine, rituximab, or rituximab alone in this condition. Sutimlimab, a few studies have reported, but it is not showing effect on circulatory symptoms. It is just treating profound anemia. There is a rapid response in these cases. But in order to control circulatory symptoms, B cell directed therapy is showing effect. So maybe rituximab, fludarabine, or rituximab, bendamustine. These type of drugs can be utilized. If there is a response, you can go for wait and watch, or rest of the drugs which are under clinical trials may be tried in these cases. AHA in solid organ transplant, this do happen because of this passenger lymphocyte syndrome where antibodies of the donor lymphocytes passively transfer to the recipient. So it is seen in 10 to 15% of the cases where major mismatch happens, like group O donor, recipient is group A. So hemolysis usually begins within 2 weeks of transplant, maybe severe, but it is transient, it goes off. The risk and extent of hemolysis are proportional to the lymphocyte mass contained in the transplanted organ. AHA in hematopoietic stem cell transplants. This is an emerging, more severe clinical entity. So after hematopoietic stem cell transplant, which may complicate 2 to 4% after a median of 3 to 10 months, with high mortality and poor response to therapies. So risk factors include unrelated donor and HLA mismatch, occurrence of GPHT, use of cord blood, age less than 15 years, cytomegalovirus reactivation, alemtuzumab use, and non-malignant conditions existing pre-hematopoietic stem cell transplant. So AAH is also associated with new biological anti-cancer therapies, which are programmed death inhibitors. So AH is the most commonly reported in these cases. Underlying conditions include melanoma, non-small cell lung cancers, kidney cancers, hard skin lymphomas, or skin cancers. So transfusion. So transfusion in AHA is supportive until specific treatments become effective. But ideally, what we see is most of these cases, the moment they see a hemoglobin of 3 or 4, they start transfusion. Complicate picture, as you can't send for any further investigations with the transfusion being done. So we can't even rule out whether that is alloimmunization or auto antibody present in the patient. Further, even these autoimmune hemolytic anemia shows macrocytic anemia picture. So most of the people start even treating them with B12 supplements, thinking it of macrocytic anemia because of B12 deficiency. So if once transfused, you can't test for B12 levels in the patient till 3 months. Uh, so if transfusion is planned, it depends upon clinical status and comorbidities and on hemoglobin level. Transfusion AHA should be deferred but should never be denied in case of severe and clinically symptomatic anemia. The first and foremost thing is ABO, it should be ABO matched, and if any LA antibodies are reasonably excluded, you have to ask the patient regarding their blood group, because most of the times this cold agglutinin disease will reflect as AB positive group. So if you ask their previous history of blood group, they might give you some clue what blood group they are having. Most of the females have their blood group done during pregnancies. That gives a clear picture of what is their blood group. In non-urgent cases, allo antibodies should be excluded without absorption techniques or extended phenotyping. Right now, genotyping is the best technique that allows for the selection of antigen matched units, which is not available in India as of now. So we have to depend upon uh, best matched units or extended typing. So transfusion management, as in all related to transfusion medicine, there should be a good communication between clinician and transfusion center. The moment you see the case, the first thing we do is we ask them to raise an immunohematological request, so that we do a DCT, ICT blood grouping and give them a clear picture stating the underlying condition and to look for any signs of underlying disease. So perform all pre-transfusion tests to ensure effective and safe transfusion. So erythrocyte transfusions are generally safer in CAD when compared to warm autoimmune hemolytic anemias. Over-transfusion should be avoided, particularly in elderly patients. So RBCs should be transfused slowly. Leukodepleted blood cells are recommended. So most of the cases, some of the clinicians will be asking washing of PRBCs, which is not recommended, because the problem is in the patient, not in the bag. So washing of bag doesn't help the patient. So this is the best matched units what they ideally do in blood banking. So where this is your auto control, which is giving 2+ incompatibility. Ideally you may get in few cases, but if you don't get, what the issue is, this unit, the strength of the unit is less than the auto control, may be selected for transfusion. So this is what we do at our setup. Whenever we see a case of hemolytic anemia, we just send a proforma to take details of the patient, which includes past and present. So because in warm autoimmune hemolytic anemia, if you see, the picture starts 2 weeks or 1 month prior. So they might be having infection, they might have used drugs, so which may initiate this warm type of autoimmune hemolytic anemia. So history is very important in these cases. Take home message, you need to maintain a good communication between the clinician and transfusion center whenever you see any discrepancies or related to the samples. Polyspecific and monospecific diet and correlate with the clinical history. So the advent of monoclonal antibodies has revolutionized autoimmune hemolytic therapy. So rituximab is one of the wonderful drug which is giving a response rate of around 70 to 80%. Further, addition of these plasma cell targeting agents, bortezomib, daratumab, have shown efficacy in refractory and severe case of autoimmune hemolytic anemias and in transplantation cases. So right now, cold agglutinin disease treatment, the entity of circulatory symptoms are not being controlled. So they're trying this complement inhibitors to complete the chain of this complement to inhibit that, so that the complement, the circulatory symptoms can be controlled. Finally, this is my final slide. So see, This picture was slide was taken from some marathon. So it always seems impossible until it is done. But as many are getting encouraged and doing participating in marathons, I request those who are participating in marathons to encourage those uh, runners to come forward and become a regular volunteer donor. As June 14th will be World Blood Donor Day. Motivate more donors to come forward, become volunteer donors. We require them. Thank you.
Any question and answer?
Yes, madam. See, first of all, what we do is whenever we see any immunological type of incompatibilities, so we just ask them to raise a request for both DCT and ICT. We just give a report and then tell the clinician to take a consent from the attendants regarding the incompatibility. So if they require blood transfusion, they can give consent for best matched transfusion, best matched units, or they may hold transfusions and they may go with the first line and second line therapies. So most of the rheumatologists and hematologists in our setup are not preferring transfusions. They are based on the clinical status. They are starting going with steroids or rituximab directly. No, it's through the clinician only, madam. So they will take consent in the case sheet and they will send a letter to us stating that the incompatible unit may be issued. Both these things have been done. It will be in the case sheet. It will be in the with the request. Yeah, yeah, yes, yeah.
Regarding the blood group, actually, because of the autoantibodies, it is always like AB picture or like
Yeah.
the reverse grouping will not counter confirm with the all. Those cases, how will we know the blood group? Because transmit without knowing the blood group, the previous blood group report also if sometimes says AB only.
Okay.
So again, it becomes whether it is the group specific or to be generalized, like to be always given O in such case.
See, whatever decision has to be taken is by the clinicians. Whatever we get, what we do is we just make a report. There is a blood group discrepancy. So the group is AB positive. So if they want to go ahead with the group or they want to give consent for universal compatible group, based on that we issue the blood. So if there is a discrepancy, they don't want to take any risk, they can go for universal compatible unit O group. Yes, yes, definitely. Only very rarely. That too
See,
in the months of November to February.
sometimes the forward will be clear, but in
Yeah,
the reverse there will be agglutination all like even and O.
yeah,
So forward will be clear cut like it is A positive or B positive, but reverse will not always counter confirm.
yeah.
In some cases, we cannot even wait till doing all the other warm techniques and all because the hemoglobin is
See,
already so low.
whatever adsorption, elution, things are there, those are academic interest because it will take time and clinicians not
Yes,
wait
yes.
2 days, 3 days for the report to transfuse the patient. So ideally, the decision has to be taken by the clinician. As per him, you have to go ahead. But anywhere, both the things should be taken. Consent be there in the case sheet as well as with you. Yes. The clinical history based on that you can give.
Sir, we have in three, and the blood group was coming like we were not able to confirm the blood group. The previous blood group also reported was B only. So our people in the midnight hours might all went with the previous blood group because we could not confirm A was as the AB was give uh, the patient actually was in cardiac failure because she was with hemoglobin and patient suddenly deteriorated after starting transfusion. He actually doubted the previous blood group report actually could be a major hemolytic reaction, because we do not rely on like what, because other, like if at all it is a standalone lab who is reporting a blood group, they would have just done the forward group and they would have given the AB positive. There is a chance of error reporting in the lab error only. That's what I felt. If the blood group is AB only previously reported, and again if you are finding an autoantibody, never go with the AB group. Always go with the universal compatible group.
Uh,
In autoantibody cases, anyway, we will expect that it is going to hemolyze. But to be on the safer side, we are just focusing to avoid the major hemolytic reaction. Acute hemolysis because of ABO incompatibility, it should not occur. So that is only my concern, where the previous reporting is also AB and now it is again autoantibody. Better not to go with AB. It will always save you in such kind of situations.
I would
So
like
to
to add,
answer, we had this patient where we had our group as AB, and I mean the patient had AB. Obviously, there was panagglutination with control
Yes.
as well. For such cases, after multiple fresh samples, we could not get any. Had informed the clinician, I will not be able now, and the previous report, I'm not going to trust. So I clearly mentioned, accept that report, and we did cross matching with all the available. Even with 30 units, I only got 2 units which are least income. So I issued, and we had got the blood. I think
That
that's
is
it.
always challenging in the midnight of the hours. These patients will be coming in the night hours only, and there will be challenges in cross matching for these patients. Technicians will be on duty, and to what to give, what not to give is always so. I personally find it very easy to make it universally compatible units, like to be given if the blood group is not confirmed, whether it is a forward, not counter confirming with the reverse or something like that.
Higher, definitively. Generally, it is generally as a clinician, what we do is we give the same blood group. Instead of knowing it
There's
is
harm in
first,
giving a O group
we can
PRBC.
give. There is no harm. We can give either way. But if you are sure it is blood group, generally we tend to give the same blood group.
yeah, I would
We
like
expect
to
that
add
definitely
something.
patient will have hemolysis.
I've seen 2 cases who group being transfused AB and been shifted to the hospital. So the first thing what we came across is when we do a grouping now, so it gives a mixed field reaction. So AB cells will be settling out, O cells will be. It took 1 day to clear. So the previous day we just hold transfusion. Next day the blood got lysed, and then next day when they send a fresh sample, it came as O positive. So ideally, this kind of scenario is seen in immunocompromised cases like diabetes mellitus. So in those cases, I don't know. Luckily, because of their low immune tolerance or this thing, so they don't land up in organ failure. So I've seen 2 cases like that.
For the, like obviously lab reports the blood group at our place, but if they want the blood group report to be released,
Yeah, you
so
can mention AB group with the mixed field features. Kindly repeat the sample. Do that.
with comments only.
Yeah,
But
comments
AB,
on it.
but can we mention AB group?
Because the sample they have sent is this. You have a doubt. You just mention in the remarks saying that there is a blood group discrepancy. Kindly repeat the sample. You can take a fresh sample and do it. When in doubt, you have to ask for new sample. That's it. In blood banking, the basic thing is even one single number is wrong. If somebody has to write 9 instead of 9, you have written 6. You will ask for a fresh sample. You will not go ahead with that sample. The same thing you have to do. Thank you.
Yeah. We'll be doing that, but asking for. What we usually do is, sir, we do not, because
I think there is
lab
high
send
tea.
us to us,
A
and
high
what
tea
we
post
do
session,
is,
I think. High tea is their post session. I will have discussed there. Let the next speaker speak. Thank you.
Please be. Sir, thank you, sir. On to the next session, that is on case-based approach in ABO incompatibilities transplantation. Take this session, we welcome Dr. Kota Narendra Kumar. Dr. Narendra did his MD internal medicine from Gandhi Medical College and DM in medical oncology from IMS Hyderabad, and did fellowship in bone marrow transplantation. Under his credit, there are multiple publication national. Please welcome.
Thank you. Good afternoon. I thank the AIG, the organizing person, the ortho for giving the opportunity. Today's topic, my topic is case-based approach in ABO incompatible transplant. I would present here more of a clinical experience or clinical perspective because my job, most of the job is done by my colleague Dr. Keith in our hospital. I'll be highlighting what are all the problems which we see in being a transplant, especially when we are dealing with the ABO incompatible transplant. So I'd be projecting the 3 case scenarios which we commonly come across. The first patient is a 4-year-old girl, beta thalassemia major diagnosis, and patient had a 100% matched donor with her sibling, that is 9-year-old female. The source of stem cells collected from the donor is bone marrow. Generally, we often do more in this time from the peripheral blood rather than the bone marrow. Because of the obvious reasons, the patients are generally afraid to undergo a procedure under anesthesia for almost like 30 to 40 minutes to donate the bone marrow stem cells. So generally go with the peripheral blood stem cell. So here the recipient, that is patient, is AB positive and the donor is B positive. And the second patient is 8-year-old male, sickle cell diagnosis, sickle cell disease, and he had a full match with his boy, male boy, that is his brother, with a sibling, and the source of stem cells again taken stem cells from the bone marrow. The blood group here of the patient is O positive and the donor is A positive. The third case is 11-year-old male with aplastic anemia diagnosis, and again he had a matched sibling donor, that is 10 years male with 100% match, and source of stem cells again from the bone marrow. The clinical scenarios, in practical, generally we are started taking peripheral blood stem cells. But traditionally and recommended method of collecting stem cells for the benign indications is bone marrow, but for obvious reason which I explained now, we tend to take more of stem cells from peripheral blood. So for this patient, blood group is A positive and the donor is B positive. This is a bidirectional issue. So who are the donors we generally prefer when we are doing a transplant is HLA matched donor, that is 100%. It could be a sibling or a matched related donor from the parents. And the other next donor which we often do transplants is from the half match, that is 6/12 match, and rarely we'll be doing the even 7/12, 8/12 matches also. But this has got little more complications than the 100% match. So generally we prefer with 100%, but as we have small families, we know everybody in recent last 10-20 years, there is a family control in India which is causing small families with 1 or 2 kids. So we are facing a lot of issues with the getting a 100% matched donor because of the small families. So since last 10-15 years in India, especially probably in China also, because of the small families, we are getting more experience with the 50% matched transplant donors, that is haplo. And rarely we do unrelated transplant, that is matched unrelated donor. Since last 2 years, even I stopped searching for the donor from the outside the family, because we definitely have 50% matched donor from our family. So we stopped searching for them at recent past. And rarely, if you don't get any of these donor, we will be selecting the umbilical cord, which is rarely done because it is not easily available. And there are issues with the cord blood transplant also, because they tend to have more infections than the 100% matched or 50% matched donor. So here the HLA and ABO antigens luckily inherits separately. So the HLA antigens are expressed in chromosome 6, and the genomic region is very important for engraftment, prediction of the clinical outcomes, and the potential harm from the GVHD or the benefit from the GVL. So when we do HLA matched transplants, that is donor stem cells from the donor, tend to have some degree of ABO incompatibility in our practice. So the ABO antigens are again expressed on the 9th chromosome and inherited independent of the HLA antigens. And as per literature, there are 43 recognized type of blood groups. I don't know how many people have seen in this hall, but this is what written in the literature. And there are 345 red cell antigens. So approximately 30 to 50% of transplants are performed across the ABO blood group barrier, and clinically significant hemolysis is seen in 10 to 15% of our cases. So antibody naturally occurring antibodies that begin to appear at the gut flora as the gut flora matures and are present clinically significant levels by 1 to 1.5 years of the life. And these antibody titers can vary from patient to patient. So ABO mismatch does not affect engraftment. This is important point in transplant. So we are not much worried if we have a ABO mismatch, but whenever possible, definitely we look at as much as possible the same blood group, and if at all possible, minor mismatches. So those are all adjustable things which we do, but as such, it won't affect the graft. Since the stem cells do not have ABO antigens and also do not affect the neutrophil and platelet engraftment also. There is no issue of graft failure or rejection if there is a ABO mismatch. So lack of ABO antigens allow for homing and engraftment of the stem cells regardless of the ABO incompatibility. That's one more important clinical point. So the complexity of the transplant mediated anemia requires a close collaboration between transfusion medicine, hematology, and transplant services. That is very important because sometimes we'll be focusing more on the clinical issues, post-transplant, lot of infection, all those issues will be there. That's where the transfusion medicine department will be really helpful for us. So, which we obviously getting from our department. So detailed knowledge about recipient, donor, blood group phenotypes, and the temporal association between transplant and hemolysis can help in identifying the underlying mechanism of hemolysis, and we can direct the different management techniques for those hemolysis. So this is basic pathophysiology, which so this box actually shows the pathophysiology. So how the anemia occurs post-transplant, it is because of the T cell and associated cytokines mechanism. And sometimes because of the mixed chimerism, the donor cells still be persisting, which can be stimulating the antibodies in the recipient. And antibody associated mechanisms like passenger B cells keeps on producing antibodies which target the RBCs and which results in intravascular and extravascular hemolysis. And plasma cells which persist for longer duration, which produce the antibodies which in turn attack the erythroid precursor cells, which results in PRCA, which is a troublesome complication post-transplant, where the clinical cooperation between the transplant unit and the clinician is very important to solve this issue. So what are the sources which I discussed in the before first slide itself, that we take most often the stem cells from the peripheral blood nowadays. We rarely do from the bone marrow because of the procedural issue, and patients are not straightward forward coming for the donation of the stem cells in the bone marrow. So 90% of the transplants are done from the peripheral blood stems. It has got its own complications. And cord blood, as I said, it is very rarely used in our centers because of the small cell dose and a lot of other limiting factors. So this short chart shows obviously the incompatibility issues. Suppose the patient, that is a recipient, if he's O blood group is there, then you have issues with all other blood groups. They have a major mismatches. And if you have a AB blood group for the recipient, that is patient, all other blood groups have only minor mismatch issues. So, and other AB and B positives obviously have bidirectional issues, and if you give a O, always it is safer, and you can give the O blood group for all the patients. So what are the issues with the major ABO incompatibility in transplant? The most common scenario which I showed in the previous slide is group O recipient from the non-O graft. Less commonly, a group A or B recipient may receive a graft from B or A, and sometimes AB. So these are the subset of major incompatible patients which we commonly see in practice. So the antibodies are IgM antibodies that can robustly activate the classical complement pathway through formation of the membrane attack complex, then which leads to the hemolysis. A major ABO incompatibility may cause the transfusion, acute transfusion hemolytic reactions at the time of stem cell infusion, especially when the graft contains more number of RBCs, which generally we see from the bone marrow grafts, not from the peripheral blood stems. So what are the major issues? So because of the recipient lymphocytes, which produces the antibodies against the donor antigens of the RBC, up to 3 to 4 months, which can lead to hemolysis of the red cells at the time of graft infusion. Antibodies stay around for many weeks, which can cause constant post-transplant anemias because of the hemolysis. And sometimes they destroy the red cell precursor cells, which leads to PRCA. So because of it can lead to again RBC delay in the RBC engraftment, but as I said in the previous slide, it will not impact the platelet and neutrophils. So RBC engraftment sometimes get delayed, and RBC chimerism also may exist for few weeks, which also can cause a delayed hemolysis. So I'm going to discuss 1 or 2 slides about the PRCA complication. So the recipient antibodies against the donor erythroid precursor cells can lead to reticulopenia, which in turn again that leads to PRCA, which is seen in 8 to 26% of the major ABO mismatch transplant. This specifically we observe most often at the first or third month, that is around day 30 to 90 days post transplant. And because of the majority of the recipients clear donor specific antibodies within 120 days, the development of PARC has been attributed to the recipient residual plasma cells that can produce prolonged antibodies. So this slide summarizes everything. You need to identify the at-risk patients. Who are they? They are the major ABO mismatch patients and the patients who are having a reduced intensity conditioning. These are the subset of patients are at high risk of the PRCA. This picture shows that the recipient is O and donor is B. And again, as the interdepartmental communication is very important to identify this problem at the earliest time. So it occurs around 30 to 90 days. So the plasma cells and the abnormal immune tolerance, which leads to production of more antibody and cytokines, which again in turn destroys the engrafting donor erythroid cells, which leads to PRC. But here most important is we should not only think about the PRC. There are other differential diagnoses which we need to consider, because here the most troublesome and most devastating complication is a TMA, which is has got severe, high mortality rates. So we need to be very alert when we are dealing with PRA, because we need to rule out other differential diagnoses like TMA. And graft failure also, because it's a very important entity which we often miss out focusing on the hemolysis component, which leading to PRC. So the treatment again, if you are having refractory anemia, you can use DLIs, you can use erythropoietin, you can use the autoimmune hemolytic therapies like IVIGs and rituximab, and plasma-mediated direct therapy like bortezomib you can use. So coming to the minor ABO incompatibility issues, the hemolysis of the recipient red cells happen in the first or second week post-transplant. the production of antibodies in the donor graft, which is the cause actually. So where you can reduce this issue by reducing the plasma volume in the stem cell, the bag. And the clinical sign is definitely hemolysis, which is seen in 10 to 50% of the patients. And the chance of delayed hemolysis due to passenger lymphocytes is seen in, again, that's as it's in the first slide, it's in 5 to 15 days post transplant, rarely after 6 to. So measuring antibodies against the recipient antibody RBC antigens, you can diagnose it. So again, little bit focused discussion on PLS, that is passenger lymphocyte syndrome. In case of minor ABO mismatch, almost all the donor lymphocytes produce antibodies against the recipient RBC antigens, yet the frequency of clinically significant hemolysis is only 10 to 15%. What are the risk factors? Again, pairing of group A or group AB recipients with group O, using peripheral blood stem cells, which itself can cause this issue, because here you have a higher percentage of CD19 B cell B lymphocytes, because you use the GCSF for mobilization of the stem cells. So this issue which can develop because of the GCSF usage. Employing only cyclosporin drugs, which specifically attack the T cells, leaving the B cells, so which again produces more antibodies, which can cause PLS. So whenever you are using a single drug, this is the issue, but most often we will be using a methotrexate, which will reduce this entity. And again, using a non-HLA matched sibling donors is the risk factors. So this picture again summarizes everything. Minor ABO mismatch is the risk factor, reduced intensity, and cyclosporin only GVHD prophylaxis is the risk factors for these patients. The donor lymphocytes produce antibodies, which again attack the RBC. And these are all the managements. Again, we'll be discussing later slide. So what are the preventive strategies we can follow or we are using in practice? If you are having a major ABO mismatch and the antibody titers are more than 1:32, your goal is to reduce the RBC component less than 20 ml, which most of the times when we are using peripheral blood stems, that will be automatically achieved. But if you see by chance more than 20 ml RBCs, you should do a RBC depletion in that. But when you are taking a bone marrow aspirate, which rarely we do, but if you are doing an aspirate from the bone marrow, then RBC depletion is recommended because you have more number of RBCs in bone marrow source of stem cells. So again, if you are dealing a patient with the antibody titers less than or equal to 1:16, here no need of manipulation for blood stem cells, and even bone marrow also you don't require to modify much. If you're dealing with a minor mismatch, you have antibodies against the donor. If the ratio is antibody titers ratio is more than 256, you need to do a bone marrow and plasma peripheral blood stem cells plasma depletion here. But if you have titers of less than 1:128, here no need of manipulation for the peripheral blood stem cells. But here marrow you can do or you cannot. Sometimes you can avoid. But if you're dealing with a bidirectional mismatch, then you need to do RBC and plasma depletion if the titers are more than 1:120. So what are the issues post-transplant? For weeks to months, the recipients develop donor hematopoiesis. That is what we do, what our intention is. Because the transplant will help in regenerating the donor, the stem cells are used and it will help in regenerating the blood in the recipient. So grafts contain anti-A, anti-B and RBCs from the donor, which amount increases with the engraftment. Recipient red cell type at first, which slowly transitions to the donor type, which in the transition phase you have a mixed field type. It's often weak due to the chemotherapy, but slow transition to the donor type will happen inevitability. And transfused blood products sometimes can obscure the transition phase, which sometimes we get confused. But once the engraftment is done, transfusions are stopped, then you get a clarity that the donor stem cells engraft and the blood group changes. So how do you monitor post-transplant? This is very important, especially when we do a transplant, everything is done, graft is done. When we discharge or before discharging, we need to little bit more focus on the Coombs test, LDH, to know the hemolysis. Obviously, these are the parameters which helps in identifying the hemolysis. So how we do monitor IgG, IgM titers? We need to monitor weekly twice from day 4, that is day +4. If the titers before transplant, if you have a more than 1:128 pre-transplant, you need to monitor weekly twice until the titers drop down to 1:60, then weekly until disappearance. And they are followed until the undetectable for 2 consecutive weeks. You get undetectable levels in 2 consecutive weeks, then you can stop the follow-up of these patients. So how do you support these patients post-transplant, that is blood transfusion? They are divided into 3 groups. Pre-transplantation, that is phase 1, from the patient diagnosed and the workup till the initiation of the chemotherapy. That is phase 1. Peri-transplant, that is phase 2, initiation of chemotherapy until the engraftment. And phase 3, that is post-engraftment, is after the engraftment. That is almost like post-transplant, complete transplant phase. So to make you understand how we deal a transplant, see, this is how we do a transplant. When we take up a patient, initially we prognosticate the patient, we work up the patient, then we the admission, we admit the patient. Then it depends on the diagnosis and the protocol which we are using. Suppose this example is shown for a myeloma transplant. Here we use GCS for mobilization of the stem cells from 5 days. We collect the stem cells in -1 day and we transfuse the stem cells in the body in day 0. That is called as day 0. Suppose I'm doing a transplant for a lymphoma, we use a beam protocol or a BUSI. Those conditioning days are almost like 7 days. So as I said in this previous slide, phase 2 start from the start of the initiation of the chemotherapy till the engraftment. So phase 2 is important, and most important again, post engraftment is also important. So these 2 phases are important, especially when we are dealing the transplant patient. So this chart shows how to deal these patients. Phase 1, it's not a big issue because you know the donor blood group and you can definitely give the patient's blood group themselves. There is no confusion here. But if you are dealing here in the phase 2 and phase 3, this table clearly shows that in the phase 2 time, you need to give the RBCs of the recipient, and the platelets, first choice is the donor. This is how you manage in the phase 2, that is during the start of chemotherapy till the engraftment phase. If you see here the phase 3, that is post engraftment, here the RBCs should be given of the donor, because by the time patient already engrafted, so you need to give the blood RBCs of the donor type of blood group. And here the platelets, you should give the first choice. Again, if you see here first choice or second choice, you will be dealing with all blood groups. That is, sometimes they ask the what type of blood platelets need to be given in emergency. When you don't know anything, you can give any blood group, but the choice again depends on the patient blood group when you're transfusing. So here, as the patient is already engrafted with the patient's RBCs, donor, that is similar to donor blood group he will be using, and even platelet also he'll be using of the same AB or whatever the platelets of the blood groups of the donor. Again, coming to the minor incompatibility, here the important issue is in the phase 2 phase, that is from the start of chemotherapy to engraftment. Here the RBCs you will be using of donor and platelets you will be using of the recipient type. Once it is engrafted, you will be using the RBCs of the donor and platelets of the recipient type. So this is how you manage. But anyway, we have set protocols which we have stick the unit, and again we have a transfusion medicine department which helps us constantly about these transfusion issues. But this is how we practice in transplant. So post engraftment, actually it is the same continuation here. So this chart will show you how we manage. It is post phase 3, it is post engraftment. Here the RBCs which we use, the engrafted donor type of RBCs we use, and that is again major and minor, the same slide which as in the. So when you do switch to the donor type of blood, only donor type RBC is present when without a mixed field issue. No transfusions for the first 3 months or 2 months. No incompatible antibodies against the new RBC phenotype can be detected in 2 consecutive samples. And 100% donor type, when you see this, then you need to switch to donor type. Negative antibodies test. Again, the same slide actually. So does ABO incompatibility impact the stem cell outcomes, which I already discussed in the slides? Likely it will impact the outcomes of the patients, either in terms of GVHD or survivals. It won't affect. And what are the variables important when we do a transplant? Baseline disease is important, stage risk is important, conditioning comorbidity is important for us, stem cell dose, stem cell source, and prophylactic regimen is important. So these are all very important rather than the ABO blood groups. So does it really affect? These are all the studies which shows the data that it won't impact the survival of the patients or incidence of the G. So ABO incompatibility poses a unique challenge clinical transplantation patients, especially when you are dealing with the blood groups, but potentially it won't affect the outcomes. So ABO matching is not required as such for the successful transplant. Transfusion support of ABO mismatch assessment is not standardized, and the decision to switch patient's blood group is highly variable across, but you'll be knowing when to change, doing the Coombs test and monitoring the blood group of the recipient. ABO is one of the single detail among all the other issues, not the very important, but whenever it is possible, we try to tend to match the blood. That's how we follow. Non-IBO, I'd like to skip because not major itself not in an important entity, but here non-IBO is not that much. Any questions from the presentation? Can
No? Even if it is a major.
yes.
Yeah, and what we are doing is we are reducing, we are adding PAS, platelet additive solution, where the original platelets will be only 80 to 100 ml.
Yeah, I mean, that issue, see, my colleague is there to take care. We are more concerned, that, as I said in the beginning itself, I'm concerned with the more in the clinical issues. These basic parameters will be taken care by Transfusion, my colleague, Dr. Keith.
Because in India, various practices are there. Like, you know, they reduce volume 200 ml and then they give it. And sometimes O group with low titer antibody. Different
Yes.
practices.
Have been make a comment on your slide. Transfusions, you commented that strategies have not been compatible. There are standard textbooks which
It is there. I mean,
yes.
I just looked at all these data from the Blood Journal, which was published in 2022.
There are British guidelines, there are American guidelines who have
Sorry, ma'am.
standard.
I'll just check that because I have taken these two data from the one is ASBMT Journal 1 and one from the Blood Journal. That's the two articles I made for the presentation. Yeah. I'll just check that. And this is my actually team which supports us for the regular day-to-day work. Thank you. So again, yes, if you really if you have a high titers, we will be using depend again. If you have a more of plasma cells, you can use the rituximab versus boti, and you can do even plasma exchange to remove the antibodies also. But as drugs wise, we can use these drugs to reduce the antibodies production also. Plasma exchange, basically, even before transplant also we did and had a bad experience, especially because we gave rituximab, we gave the cyclophosphamide to reduce the antibodies before transplant to reduce the antibody titers. But almost I did for 2 patients. Unfortunately, I never had a good result. So that is the reason either before transplant or after transplant, plasma exchange for me, it's not a good technique for to do it in the first level. I'll be preferring more of a drug-oriented therapy rather than the plasma exchange because twice I had a bad experiences with the plasma exchange. Actually, that is a big issue when we are doing a transplant. So that is the reason when we collect the stem cells, we see the stem cells. Suppose if you are having more than 5 million cells only, we'll be attempting these all techniques. If the stem cell quantity is very less, we will not be manipulating the product that much because again, we are concerned. Yes. And especially surprisingly, we do more often haplotransplant at our center. I don't know, we get more like that. So here we require more stem cell content, like we require more than 5 million cells per kg body weight. So we have that luxury when the stem cell count is very less, that luxury is not there. So we can do that only when we have more than 10 million cells. We can manipulate the stem cells. But when you're collecting the stem cells itself, we discussed with the transfusion doctor that there are less number of RBCs can be there in the collected the product. That is advantage of even with the peripheral blood stem cell collection. Yes, separator. So if you are doing the stem cell collection from the bone marrow, you will have these issues because you have more number of RBCs there. You need to RBC depletion, all those things are required. But most of 90% of our transplants are done from the peripheral blood stems. So we don't have that issues much of it. And fortunately, we never seen any complication of this sort in all our transplant patients. Manipulation. Okay. But I don't know how many centers in Hyderabad is doing from the marrow. I doubt that. Only recently I attempted for one patient who came from Africa. They are twins. So I don't want any the GVSD. So I did a collection from the bone marrow. That too, it took for us almost like 45 minutes. So that really painful for the kids and even the donor. So we literally thought that we will not do anything. And by our own experience, I didn't see anything much advantage doing whether you are collecting from the peripheral blood or the bone marrow. So for me, doesn't really make a much difference. There are even data also showing that GVS device 100% match from bone marrow or peripheral blood stem cell collection. At least the difference of GVSD is not great, where you are really encouraged to do from the bone marrow. So especially when I do a transplant for the malignant indications, I'm more comfortable doing the peripheral blood stem cell collection there. Even for benign also I'm doing that, but especially malignant indications, I'm more comfortable from peripheral blood stem cells.
Thank you, sir, for taking out time from you. Request Howard. Move on to the last session. We welcome Dr. David Roxby back now. Now the session is on algorithm-based approach in the immunohematology testing and the management of ABO incompatible solid organ and stem cell transplantation. Thank you, sir.
Thank you. So, as we've heard, transplantation can occur using hematopoietic stem cells from a number of different sources. They can be allo or autologous, but also transplantation can occur with solid organs, for instance, kidney, liver, heart, etc. So, from a transfusion perspective, there's a number of considerations that we would think about. What's the donor ABO type and the recipient? Do we need to do extended phenotyping, ABO matched transplant? Just heard about the antibody titers, the risk of hemolysis, group and screen results, DATs, HLA alloimmunization. But from a laboratory inventory management perspective, we need any special attributes for the red cells we're going to transfuse? Do we need CM negative? Do we need irradiated? Similarly with platelets, do we need irradiated or CMV negative platelets? Then the consideration of granulocyte transfusions. So importantly, patients may move around. They may have a transplant at one hospital, and then once they've covered, they go to another hospital. So it's extremely important that transfusion details and transplant history is communicated to the second hospital. So we've heard about the ABO group. Why is it such a problem? First described in 1900 by Landsteiner. He described AB and O. Then a number of years later, some of his colleagues described the AB. The interesting thing about the ABO blood group system, it's not just restricted to red cell. It's found on most tissues in the body, solid organs. It's also found as the antigens are found in a soluble form in various bodily fluids if that person is a secretor. It's a simple structure on the red cell surface. It's a simple structure on other tissues. The genes associated with the ABL antigen do not lead to the direct gene product, so that they lead to the production of an enzyme, a transferase, that adds a specific sugar to a precursor substance. So the precursor substance is a prime basic carbohydrate. So with the action of the H gene or the foot gene, it adds a fucose to this precursor substance. That's your group O. So Bombay people lack the H, and they've only got this precursor substance on them. So in a normal ABO biochemical pathway, the H antigen is the building block for the A or B antigen. So then if you possess the A gene, it leads to the production of specific sugar that adds sugar for group A, which is N-acetylgalactosamine. If it's B, it adds another galactose. Now, there are different linkages with these sugars, and they occur in different tissues, and that can influence the antigenicity or the expression of those antigens on different tissues. So we all inherit particular antigen at tested, not very strongly. The interesting thing about this is that the ABH antigens are commonly found in the environment. Foods we eat, pollens, bacterial surfaces. So if we lack the particular antigen, let's look at group O person, they lack the A or the B and the B antigen. So they will produce anti-A and anti-B as you know, the babies, newborn babies don't have anti-A and anti-B. As they grow, as they're exposed, they produce anti-A, anti-B, or anti-AB, depending on what antigen they have on their red cell. Why are we so interested in the ABO antibodies? Because IgM, it's in high titer, it activates complement extremely well, and if we give incompatible red cells, so if we give A to an O, it will lead to an intravascular hemolytic transfusion reaction. There is also a small amount of IgG, more so in group O people. Make it a little bit more complex, in the ABO system, in group A, B, or AB, you can have what is called subgroups. So the most common subgroup of A is A1, A2 is the second most common, and similarly with AB. And you can also find subgroups in B, but subgroups in B are more common in people of Asian origin because the frequency of B is higher in Asians. So that means that you have different expressions of the different antigens on the red cell, not only in structure, but frequency. So we've heard about in detail ABO incompatibility, the major, the minor, and the bidirectional mismatch, which I'm not going to talk about. We've heard the risks of ABO mismatch from a laboratory perspective, the findings that could be present, and also we've heard about passage of lymphocyte syndrome, so the transplant donor B lymphocytes that continue to secrete an antibody that is incompatible against the recipient's red cells. We've had this well described about what are the potential clinical consequences of a major, minor, and in a bidirectional transplant. And again, we've heard about the 3 phases of transplant: the pre-transplant, peri-transplant phase, and the post-transplant phase. and what group specificities you should be giving. So pre-transplant patients, same blood group. Peri-transplant, group that is compatible both with the patient and the recipient. And post-transplant, the group of the transplanted tissue. And again, you've seen this table. So post-transplant, this is what we would work to in our laboratories. And we've heard about the need to deplete red cells from the graft. Also, if it's bone marrow collection, if it's a minor mismatch, to plasma deplete and decrease the level of plasma. So here's a case of an ABO mismatch transplant. The patient was originally group O negative. It's a major mismatch. The donor is an A positive. So this form is completed when the patient is listed for transplant, and it provides, and it's sent to the laboratory, and it provides details about, does the patient need radiated products? Do they need CMV negative? And then what group that should be given during that transplant period. And this is an example of the worksheet for this mismatched patient. So again, group O negative transplanted with A positive. You can see that the native blood group is group O negative there, but then we get into this mixed field stage where it's the starting, the engraftment of that A unit, and following doing it by a couple of different techniques, and as it engrafts, finally changes to a group A, and that's where you'd be giving the donor blood group. So I want to concentrate a little bit on some of the technical problems or issues or controversies that surround antibody titration. So what are we looking to detect? We want to detect the level of antibody pre-transplant, probably post-transplant. What most important class of antibody? Do we worry about IgM? Do we worry about IgM that's reacting at 37, IgG that reacts at 37, or IgG that's reacting by the indirect antiglobulin test? And then what technique do you use to do your titrations? Tube, solid phase, polymer agglutination technology, manual or automated techniques? What temperatures are you going to incubate your test at? Is there a difference between using serum or plasma? Should you DTT treat your serum sample or plasma sample to remove the IgM? What indicator cells would you use? How do you score the titration? Do you 0 to 4 or 0 to 12 scale? And what's the definition of your endpoint for titration? So a number of years ago, we did a survey of hospitals that did transplants, whether it's solid organ, hematopoietic stem cells, or both. And you can see these are all the different techniques that were used for titration. So it makes it extremely difficult to compare results between different institutions and say, does the result for a titration done at room temperature, is that equivalent to one that's done using CAT technology? No. And so, different titration methods. Here we've got room temperature, 37 degrees, and IAT, but different titration levels. Which one do you report? Obviously, 1 in 1,024 is extremely high. Or do you just report the 1 in 8? So if you're using your titrations as a guide to plasma exchange, which one is relevant? I can't give you an answer. It's a universal problem. And then, do we add diluents to our indicator red cells? Are the red cells just suspended in saline? Do we add an additive? Do we add albumin? Because by adding additives, it could increase sensitivity and increase the titration level. And then again, is it then applicable to compare titration using albumin or red cells in albumin with red cells in saline? What's the correlation? What are the endpoints? You can see here that laboratories are these are on a 0. Yeah, these are on a 0 to 12 scale. 2, 3, score 11. What does that mean? So again, what's your highest titration? What's your cutoff point? So this laboratory used a 0 to 12 scoring. So you can see here that this 2 is the 4, but they're reporting on their final reaction with 1,004. So, and then some laboratories report different cutoffs depending on what tissue's being transplanted, whether it's hematopoietic stem cells or whether it's a solid organ. So we've heard the options we may need to decrease the level of circulating antibody. So we've got a number of options. Plasma exchange, a straightforward plasma exchange. We can use an adsorbent column. Some hospitals even use donor plasma to as well. Remember I said about 80% of people secrete soluble A and B antigens in their plasma, so that you could use plasma plus other immunosuppressive agents. Now, what about the use of irradiated products? So irradiated red cells, irradiated platelets. Just recently, we've updated our guidelines through the Australian and New Zealand Society of Blood Transfusion. These are based on objective data, are recently released this year, and it says that all allogeneic stem cells receive irradiated cellular products, so red cells and platelets. What about platelet transfusions? What's our thresholds for platelet transfusion in settings? So patients undergoing chemotherapy, in transplant support, if there's no risk factors, then you want to try and keep the platelet count above 10. But if there are associated risk factors, at above 20. But if there's invasive procedures, you want to keep those platelets above 50. But what about platelet refractoriness? What do you do in a setting like that? So platelet refractoriness can occur either because it's related to an antibody problem, whether it's HLA, HPA, ABO compatibility. Remember, platelets do possess small amounts of the ABH antigens, graft-versus viral infections, etc. Or we've got the non-immune, so infection, fever, drugs can affect it, splenomegaly can affect it. So what's the process if a refractory patient? Obviously, we like to know the corrected count post-infusion. If we're not getting a response, do we have to provide HLA matched platelets if available, or HLA epitope match? What about the presence of leukocytes in our transfused products? They can lead to or contribute to alloimmunization of HLA, modulation, transfusion-associated graft-versus-host disease, Raleigh, and various infections, and they may actually impair the quality of the stored blood. So there's a number of ways to provide either CMV negative or CMV safe product. CMV negative, we screen our donors, or the other option is to provide leukocyte depleted product at the time of collection. So leukocyte depleted product is not CMV negative, deemed as CMV safe. So a number of countries now have moved away from CMV screening of their donors, and they have universal leukodepletion. They don't have CMV negative product. Australia's moving towards that. It's still there's still two different schools of thought, but it's probably more effective. And I believe here in India, the CMV positivity is about 90%. Yeah, whereas in Australia it's 50%. So again, you've got to look at your own populations. So we're fortunate in Australia, we have universal leukodepletion, and had that for a while. So leukodepleted red cells, leukodepleted platelets. A number of years ago now, safety of blood Tissue and Organs Advisory Committee from the UK put out a statement, a consensus statement saying CMV negative red cells and platelets may be replaced with leukodepleted components to provide those products. So which groups of patients should receive leukodepleted? Which group of patients should receive CMV negative? So you can see here solid organs, stem cells, onc patients, even with HIV. Leukodepleted is appropriate. CMV negative is highly recommended in people with a primary immunodeficiency, premature infants, or fetuses that have undergone a uterine transfusion followed by an exchange transfusion, pregnancy, but not at the time of delivery, so antenatally if the mum has a bleed, and granulocyte transfusion. So the list has been decreased significantly. Granulocyte transfusions, then, yeah, they're used more frequently than I'm used to. Invasive infection that's not responding to the appropriate treatment. Granulocytes can be made from buffy coat preparations, or they can be collected by apheresis. So I'll just spend a little bit of time now on solid organ transplant. And again, ABO incompatibility is a significant barrier. So we can ABO mismatch transplant these patients, but we want the antibody level at quite a low level, a safe level, that's not going to lead to acute hyperrejection of that mismatched organ. So ultimately, we want that organ to survive, and if we're doing a minor mismatch in a solid organ, so O to A, risk of a passenger lymphocyte, be aware of that. And again, for renal transplants, there's recommended guidelines for the different ABO groups in ABO mismatched transplant. So again, titration plays an important part. ABO antibody titration plays an important part in ABO mismatched transplant, because we want the antibody level to be at a safe level, that transplanted organ will survive. Now, in Australia, I know here in do a lot of living-related liver transplants, so you do a lot of ABO mismatch. In Australia, we do cadaveric, so it's very rare to an A to an O liver recipient. We'll do an A2 to an O. Don't do antibody titrations, really, because we don't have time. Cadaveric transplant, and we've done a number, and they've been quite successful. And again, just to demonstrate the differences in titration levels using either automated or tube techniques. So, the variability in reporting titrations and technique is there. So we're aiming to have a titration level around 8. We wouldn't go ahead where it's really high. Wouldn't even attempt to decrease greater than 500 and 512. So what about the variation in clinical hemolysis in patients with the same titer? Why? So let's look at the recipient. ABO, the antibodies have variable binding antibody. You may have a higher level of IgG than IgM. The degree and rate of clearance by the reticular endothelial system, and the variability of binding and activating complement. Then if we look at the donor, the variability of antigen density, structure of the antigen on the tissue as well. So that's taking all those together, it will influence risk of damage. What about the cellular damage? Again, it comes to the binding type of antibody and antigen density and structure. And then we come back to the variation Theta technique. So this is where I've had most experience in tissue transplant livers. So for our liver transplants, our patients would go through the standard group and screen, ABL-RH antibody screen. Screens positive, identify any clinically significant antibodies, work out the compatibility frequency. For red cells, we didn't worry about CM status. The surgeon, the liver clinicians were happy with completed. The donor was only matched on ABO and size. So a small person. As I said, we've given A2 to O, previous no titrations and no issues with that approach. HLA compatibility is not important in transplants. We're renal and heart transplants, so we undertook a number of liver kidney transplant where the recipient had high titer multi-specific HLA antibodies. And so by doing that, the liver acted as a sponge that was able to absorb the HLA antibodies and not affect liver function, and the transplanted incompatible kidney survived. So what about actual transfusion support in liver transplant? So our approach was we'd be notified. If the patient had clinically significant antibodies, we would try and these transplants could happen at any time of the day or not. We'd try and hold a number of antigen negative red cells in inventory. We had an active list of patients who were on the transplant list, and then when the transplant happened, we'd had enough to start the transplant. In the meantime, we'd liaise with Ross to get more. What about if you had the scenario where you had a massive transfusion or a critical bleed in the setting of, say, someone like that with 5 antibodies? We had a process where we'd have antigen negative blood, start a surgery, and if there was this significant bleed, would move to incompatible blood, reserve some antigen negative blood, and that was an accepted procedure. What we've done most recently, we had a patient with 6 significant antibodies. So we sent samples off to New Zealand for the monocyte monolayer assay. It's an in vivo assay that understanding of the clinical significance of the antibody, because all the antibodies she had clinically significant, but it gave us an indication of the risk of hemolysis, and 4 came back with no risk. So we were able to ignore those 4 antibodies, just have 2 antibodies we had to concentrate on, find antigen blood, which made it much easier. We don't have a specific algorithm for how much blood we would have when we're notified for these patients. Our approach was to diagnosis of the patient, the underlying reason for liver failure, any previous transfusion. We would there the recent Hepatology OAG screens. That would give a guide on how much blood. So on average, would take 2 or 3 units into theatre, 2 units plasma, and have 2 units of platelets in the theatre. We had the advantage that someone from the transfusion laboratory or blood bank was part of the liver team. So we had close communication, and we had ROTEM in theatre, so we could see what was happening and be very proactive. And by doing that with the use of ROTEM, we were able to significantly decrease the product. And many a time, transplants don't use any product. The passenger lymphocyte syndrome, as you've heard from the previous speakers, due to the transplantation of donor lymphocytes that can continue to produce an antibody. Most of the time, it's directed against the ABO. So if you're transplanting an O to an A, that antibody is directed against the A red cell of the recipient, can lead to significant intravascular, but it's not just related to the ABO system. It can occur in other blood group systems, but the hemolysis there, due to IgG, and it's extravascular. So for instance, RH, we've had some extravascular, self-limiting, disappear after a period of time. But the drop in hemoglobin's really quite sharp. The typical findings, it looks like an ABO mismatch transfusion for the ABO, passenger lymphocyte syndrome. So you'll have all those expected laboratory findings. So you've just got to support the patient with group compatible red cells. That's all we did. At times we considered plasma exchange, but we didn't. So this is just one case of passenger lymphocyte syndrome. The recipient was an A, the donor was an O, and on day 10, I think it was, his hemoglobin had fallen down to the day 10 post-transplant, had fallen down to about 60. And you can see he'd received a couple of 5 units post-transplant on a single occasion. He presented with falling hemoglobin, no history of bleeding, group mismatch. So he was originally an A, but he was getting in his reverse group plasma reacting against A red cells as well. DAT was positive for a period of time, eluted anti-A from his circulating red cells, transfused group O red cells. Day 101, antibody screens negative, DAT's negative, hemoglobin 105, and he was fine. So in relation for transfusion and transplantation, we need concise transfusion policies for the use of product prior to, during, and after transplant. What are there any special attributes of the trans products we've talked about? We need ready access to medical records. We need communication between all groups. Patients discharged to a rural hospital, we need to ensure that they have the appropriate pieces of information well for transfuse the correct products. So with that, again, I'd like to thank you all for your attention. Thank you very much.
Any questions?
Titers, IgM titers, IgM and titers.
Yeah. So that's the dilemma. Do you report total? Do you report IgG or IgM? Some institutions are just reporting total. I think that's the way that it's going. And you talked to a number of renal transplants. They say IgM may be more important because they're finding a complement. Done some studies, pathology studies, looking at complement deposition. I don't know what the right answer is. In Australia, we tried to develop a standardized approach, but it was too difficult. I did approach the International Society of Blood Transfusion to organise a working group. So we've got some form of direction and understanding and awareness of the challenges. I don't know what the right answer is. I guess it's need a study to correlate the outcome of whether you report IgG or IgM, whether you report total.
So, ladies and gentlemen, now it's end of the session, and we thank you all for your valuable participation and presence over here. And heartfelt, thank you to Dr. Roxby for taking out his time. And we know that, so you are like from past 10, 11 days, you are continuously in one another city. But we definitely, we are blessed to have you because your passion of, sharing the knowledge is incredible. And we are really blessed to have you here. Apart from that, we are also very thankful to Dr. Tota Narendra sir. Sir, your valuable time you have given to us, it's really helpful for all of us. And Dr. Srinivas, for you, sir, thank you so much for your valuable time and insights which you have given to all the audience. Plus, the audience who are here, we know that you all are dealing, blood banks, which is a very critical area. And from your busy schedule, you have given time for some learning and development. It's a great thing to have you all here. And last but not the least, the KIMS management as well as the AIG management, Dr. Kirti ma'am and Dr. Pragati ma'am, your initiative to help us out to organize this wonderful event is a great thing to have. And we all thank you. Thank you to all the AIG team members. And last but not the least, my Quidal Ortho team members, Mr. Naveen, Mr. Azhar, Mr. Santosh, Mr. Rajesh, and Naresh. Everybody, all of you have put a lot of effort for this. And we'll keep meeting all of you. We'll keep continue these educational activities because we feel this is one thing which we should, come together, learn together, and grow together. So with this, thank you, all of you, and have a nice day. And now I request all of you people to please come forward so that we can have a group photo to have it as a memory. Please come forward, everybody.